didactic content is intended for global training and education purposes only. Candela Corporation and its affiliates make no representations regarding federal, state, local laws, or regulations that might apply to use and operation of this device. For this reason, please review your country's current indication for use as provided by the respective regulatory agency. This content is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Treatment considerations are under the discretion of a qualified licensed healthcare professional. Individual healing times, discomfort treatment results, and satisfaction can vary. Please discuss these as well as risks and benefits of this procedure with your qualified healthcare professional to determine whether this procedure is appropriate for you.
Thanks very much, Grace, and thank you everybody for joining us this evening. Welcome, a warm welcome to you from Boston, and we're very happy to host this for our European colleagues this evening, and very, very happy. I'm excited to be able to listen to this webinar along with moderating it because we have two fantastic experts on this evening, Dr. Adriana Ribé and Dr. Pedro Santos. Dr. Ribé is founder and director of Ribé Clinic in Barcelona, Spain, as many of you know, which is a wonderful medical center that she's been part of for many years. She's got quite extensive experience and a distinguished career, having trained here in the United States as well as in Spain. And she is also, in addition, a dermatopathologist with a special expertise beyond dermatology. So we're very, very honored to have you here, Dr. Ribé, and look forward to hearing all of the interesting cases that you'll share with us. Dr. Santos also holds a master's degree in medicine from the Abel Salazar Institute of Biomedical Sciences in Oporto, and he joins us from Portugal. He's done his master's program in aesthetic and anti-aging medicine at the Complutense in Madrid, and he is co-founder of the first postgraduate program in aesthetic medicine in Portugal, so a leader in aesthetic medicine in Portugal. And so we're very, very happy also to have you join us as well, Dr. Santos. So with that, let me move forward to the other star of our show, which is the PicoWay laser. And we've all been users, I think, for almost 10 years now of this laser, I would say. So we have many, many experiences to share with regards to Pico Resolve, with regards to treatment of pigmented lesions, with regards to skin rejuvenation and later tattoos. But Dr. Ribé is going to focus on predominantly pigmented lesions and skin rejuvenation and share her expertise. And I'll turn it over to you, Adriana. Thank you. Adriana, I think, Dr. Ribé, if you would just click your mic again. It seems we can't hear you. Perfect.
Do you hear me now?
Yes.
Sorry. I was saying that thank you for the kind invitation. It's a great pleasure to be here with you, with Candela, and with Pedro as well, sharing this masterclass. So I'm going to talk about Picosecond Laser in rejuvenation and pigmented lesions. As we all know, the Picosecond devices were first created to remove tattoos. We still have the idea that with Picosecond lasers, we do tattoo removal. But currently, Picosecond lasers are also used to treat aging signs such as pigmentation, disorders, fine wrinkles, skin laxity, and acne scars. And we can do that because they have several wavelengths and as well several modes of action. This is the laser, as Konica was saying. This is the PicoWay. This is the Picosecond laser from Candela. And this laser has different hand pieces. So far, right now, we have 6 hand pieces. As here, I want to show all of them to you. We have the result. Well, let's start by the zoom. That is the first we had, which is 532 and 1064. And then we add the 785 and recently the 730. And then we have the 3 fractional hand pieces, which are called Resolve. We have the Resolve 532, the Resolve 1064, and the Resolve Fusion, which is the new one. So it's a laser with 6 different hand pieces. And with all these hand pieces, we can do many things. As I said, we can do tattoo removal. So based on the color, we select a different hand piece. Usually for red and yellow, you use the 532, for green and blue, the 785 and the new 730, and for the black and other colors, the 1064. But just focusing what we're going to talk today, for benign pigmented lesions, we can use the 532, the 730, the 785, and the 1064. And we want to improve texture in the skin, then we go more to the result hand pieces. And based on what we want to aim and the phototype, we will choose one of the three we have. So just the idea to say we have in a picosecond laser 6 different hand pieces that we could use to do tattoo removal and as well for pigmented lesions and skin rejuvenation. These are the two new we have. On the other hand, we have different modes of action. Once we have chosen the right hand piece, we can use a zoom mode, which is like the tuning, the painting technique. We can use what we call explosion, but you can use other ways, but explosions mean selected shots in the lesion, or we can use the fractional. So we can use 3 different modes of actions depending what we want to treat and what we want to achieve. Before starting with the cases, I always like, as a dermatopathologist, go through the slides, the microscopic slides. When we talk about fractional, which I think is the new thing in these picosecond lasers, when we think in fractional, we all think in the photothermolysis, when we started using fractional devices. And the way the energy is absorbed in the skin is a linear column. There is an absorption of a column that affects the epidermis and dermis. This is for the fractional devices that work with the photothermolysis technologies. When we use fractional devices with the photoacoustic, which is the picosecond, is completely different. It's not a linear absorption. It's like an explosion in the skin, either in the epidermis or in the dermis, creating these areas of high energy, which is what are called the layers, but it's completely different. This is very important to keep in mind the way they act. So going to the fractional hand pieces, which in the PicoWay are called resolve, we have 3, the 532, the 1064, and the Fusion 532. The way they work is like in the lens, we have an holographic diffractive optic that what it does, it creates, as I said, high energy pattern of fractional injury. It's like a concentration with plasma formation. And then what we do is we make like a hole that can be in the epidermis or in the dermis based on the energy we use. But that's the way they work. It's not a linear absorption. In the PicoWay, what we can see comparing to other lasers, the way the optic has is we can have 100 points with the same exact energy. It's an even distribution. So that is what we see, 100 dots with the same energy. With other lasers, which are, for instance, the one that they use, the microlens array, you have the energy, but it's not evenly distributed. With the new result, which is the Fusion 532, you have the same energy in dots, but surrounding every dot, you have a diffuse irradiation that covers 50% more. So after the treatment with this handpiece, you get more area treated, you get more heat, although it's not a laser that is a little bit cold, but you get a little bit erythema, inflammation, and downtime. That's still minimal, but you get some comparing to the other handpieces. And this is important to know when we're going to choose the phototype of the patient and also knowing the downtime. Let's go to the cases, but just as a summary of what I've said, we have a picosecond laser that instead, you can do tattoo removal, but you can do rejuvenation, you can treat pigmented lesions, and that is thanks to different hand pieces and different mode of actions. So let's go first to talk about benign pigmented lesions. I've chosen lentigos, dyschromia, and nevus of Ota. I didn't choose melasma because I don't have much experience. Dr. Pedro Santos, he has more. So I think if we can add something else, that would be very helpful for us. Lentigos is very easy. You can use in the explosion mode. You go directly to the lesion, and then you get some crusting. Usually you do 1 session, sometimes you need 2. and after the treatment, you get a crust. Not always, you do not always get a crust, and then you prescribe a repair cream, and as well, if you want, serum with tranexamic acid and sunscreen. This is a case before and after with the Picosecond laser. You can also do this with other lasers, yes, but if you have the Picosecond laser, you can treat lenticels. This is a patient after the treatment. You have this crusting, the lesions. You do not always get the crust. It depends on the amount of pigment, but they heal very fast. After 6 days, they are almost gone. And one thing I would like to talk about the picosecond lesion in pigmented lesions is about Asian skin. Asian skin is a very difficult skin for us because they behave as a phototype 5. And with Pico, I'm very happy with all the patients I was able to treat. We have to think that the Asian population represents more than half of the Earth population. So we have to be ready to treat this population because it's a huge amount of people. And in Spain, we're getting more of this group of Asian people. And as I said, the skin behaves completely different, and they have a lot of hyperpigmentation. So we have to be very helpful. Just to give an example, for instance, L'Oreal has recently inaugurated a research center in Pudong in Shanghai only to study Asian skin. So that's why it's so important, and we cannot treat Asian skin with other lasers. With IPL, with alexandrite, you can, but the chances to get hyperpigmentations are very high. So with the Picosecond laser, you have an amazing tool to treat these patients that every time you will get more in your offices. And that's what I'm going to share with you cases of Asian skin. This is a patient with lentigos. The patient also has nevus, but the patient has lentigos. This, in a phototype, a patient like this, phototype 1 and 2, is extremely easy. But a phototype 5 Asian skin is difficult if you treat with other lasers because the chances of hyperpigmentations are very high. So in this patient, we did 3 sessions with the 730 just on the lesion, and then after the 730 in every lesion, like a full pass with the 1064 result. So we're treating the lesion and as well the full face. And you can see after 3 sessions, we got ready for all the lesion except the nevi, and the skin quality is very nice. You can see that has a lot of glow. So we're treating the lesion and the skin with no post-inflammatory hyperpigmentation. This is another patient. You see these subtle lentigos, but this is the kind of lentigos Asian skin has, and they are very worried about this. And with Pico, you will always be very successful using the 730 in every single lesion, as well as 1064 in the full face. Usually I do 3 sessions, but sometimes in 2, you get very good results. This is another patient with solar lentigos. And as I said, you can see these lentigos that they look very mild, but they are extremely difficult to treat. This is another patient. This is very typical. They are young patients, but they have these lentigos. And with Pico, with 2 or 3 sessions, combining the 730 handpiece and the 1064 resolve, you will get very good result. And also I want you to see as well the quality of the skin. They are more glow and the pore size is less. Now let's talk about this. Yes.
Okay. Can I ask a few questions?
Sure.
For when you do these treatments with the burst mode, do you do a single pulse, or what is your treatment endpoint, and how many pulses will you do with the 730?
It depends on what I see. It has to turn a little bit gray-white. If the lesion is very dark, sometimes with 1 shot is enough. Sometimes I have to do 2 or 3 pulses. So it depends on the lesion. But I need to see this end point a little bit grayish, a little bit white. I need to see a change.
And not too white. So it sounds like you're not looking for too white.
No, and one thing, if the patient comes with a pigmented lesion that has been treated somewhere, and I'm doubting if it's a lentigo or a post-inflammatory lesion, post-inflammatory hyperpigmentation. After 2, 3, 4 shots, it doesn't turn gray, it's not going to go away. This is post-inflammatory hyperpigmentation. So it's very important to do, and it's a little bit of pain because you have to put the glasses, remove them, check, but it's very important to see that the lesion get some changes.
That's a great point. And what about when you're doing the resolve? What is your end point there? I know it varies depending on the skin color of the patient and the type of type of skin, but in general, how do you choose your parameters? How do you choose the number of passes? Can you share a little bit about that?
Yes, usually what I do at the very beginning, we were doing many passes, like 10,000 in the whole face. Then we realized that with 4,000 was more than enough. So I like to see some redness, but I have to say Asian skin is extremely sensitive. So it depends on the skin, but I like to see some redness. Some patients get a pinpoint bleeding. I don't like to reach this point, but at least to get some redness is around 4,000 shots in the full face.
And do you like to use a high rep rate or a lower rep rate depending on the skin type? Do you change your rep rate?
Yeah, completely. We did a histological study and realized that if we use high fluences, then you get the layers in the epidermis, whereas with low fluences, you get them in the dermis. So I don't think going to high fluences is getting a lot of benefit. So as I said, here is like 1.70 with the spot 6. Usually use 6. Sometimes when I'm treating melasma or nevus of Bota, I start with 8. The spot 8 going deep, but usually I work, well, the result always has the same spot. But this is the fluences I use, 1.7. Usually I try not to reach more than 2.
Oh, that's very interesting. We have a question from the audience, and I think we should maybe back up and explain a little bit about the wavelengths here. The question is about using 1064, and this question is that the listener says that 1064 is normally a deeply penetrating wavelength. So why do you use 1064? Doesn't that affect the D junction? Would that be safe? And so I think that the clarification here is about the picosecond versus a long pulse laser.
Yes, the picosecond with the 1064 is aiming the epidermis and the dermis. With the picosecond is not that much related to the wavelength, it's more related to the energy, the fluency you're using. Because we did a study with the 532 and the 1064, and you could either get in the epidermis or in the dermis, but the most important is not the wavelength, the most important is the fluence. And after I'm going to show a result with the 532, and for me the most important, the 532, I only use it for phototypes 1 and 2. It's more the phototype what I want to aim. What I want to aim relates more to the fluence than to the wavelength. So 532, the fusion especially, I use in phototypes 1 and 2. I use when I got it at the very beginning in Asian skin, and I will show you what happened to me. So usually the 532 for me is phototypes 1 and 2. Some people know, I know that for melasma, they do a combination with the 532 and the 1064, but for me, I'm a little bit careful with the 532 in pigmented lesions and in high phototypes because it's very strong.
Thank you.
So this is another case. Before I was talking about lentigos. Now I'm talking about dyschromia, which is this diffuse hyperpigmentation and a post-inflammatory hyperpigmentation. This patient was treated with an IPL. And then, as I said, this is not a bad word. It's something that happens very often when you use an IPL in Asian skin. It worsens. You get a lot of post-inflammatory hyperpigmentation. So in this patient, I did 2 sessions of Resolve 1064 in the full face, and the patient was very happy in combination with creams, with bleaching creams. So when you have a post-inflammatory hyperpigmentation, you can manage with the Resolve 1064 and bleaching creams, usually with tranexamic acid, and sometimes you can use some with retinol at night, like very, very soft. Asian skin, as I said, is very, very sensitive, but it can help to treat the dyschromia and the post-inflammatory hyperpigmentation with the 1064 Resolve. Now, I recently had a patient that she had many bites. She's from South America, phototype 5. She had bites and a lot of post-inflammatory hyperpigmentations on the legs. They were completely gone with 3 sessions of the 1064 Resolve, only in every single lesion. Of course, as well, combining with creams. So the 1064 Resolve helps a lot with post-inflammatory hyperpigmentation and diffuse dyschromia.
What do you think the mechanism is, Dr. Ribé, being a dermatopathologist? What do you think is happening at the level of the skin cells for PIH and 1064 Resolve?
I think the PIH is like all the melanin in the macrophages. So I think it's like when you do, this is an idea, I don't know. When we treat tattoos, the ink is not in the dermis. The ink is in macrophages as well. So I think in a way, it must be a way that there is an absorption of this pigmented in the macrophages that is helping. And also, I think the picosecond lasers, they are more with an acoustic technology than more with thermal technology. And I think it helps in getting rid of the pigment, like breaking the pigment, as well as avoiding all this inflammation and all this heating. But I'm not sure. This is just an idea, but it's a way that you are able to destroy the pigment that is inside the macrophages and as well, I guess, in the dermis. But it's like you are like breaking everything here. You're shattering everything, but I don't know. Maybe Dr. Pedro Santos can give us more ideas about this. But with the post-inflammatory hyperpigmentation, it's difficult to know the mechanism, but it's acting. But I think the Pico is able to go very deep in the dermis and producing less of photothermal effects.
Interesting.
I want to share you a nebus of Ota. This was treated with a Zoom. This is a case that I was treating the patient, then she got pregnant, so it was over a period of 3-4 years, and then we did some sessions before, some sessions after, and at that time, I only had the Zoom, which is the 1064. And this is a patient with an nebus of Ota, and then we did 6 sessions, and I always start with the spot 6 or 8. Dr. Firas, but we had an argument sometimes, we start with a spot 2-4 because he gets a lot of energy. I love the energy, but I think nebus of Ota, as a dermatopathologist, the pigment is very, very deep. So it's good to combine both things. My case was with a spot of 6. I did 6 sessions in this patient. She was very happy. Then she was pregnant. She came later on. And then we did 2 more. Oh, I'm sorry. There is another picture, but for whatever reason, it's not here. The lesion was completely gone.
Oh, wow.
Except around.
Sorry. And did you stay at 1.7?
Excuse me?
Did you subsequently also keep her energy levels at 1.7, or what was your?
In the same session, I was doing a spot 6 or 8, then going to spot 4. And in this case, I was getting pinpoint bleeding, but the lesion was completely gone, except around the eye, around here, but it was completely gone. And it was an Iota. The patient had a biopsy here, but the lesion was completely gone. Sorry, because I thought I had the other picture.
No,
we did 8 sessions. We did 8 sessions. So what I want to say is that benign pigmented lesions you can remove with Pico. You can also remove with other devices, but the key here is you get almost 0 post-inflammatory hyperpigmentation. And this is very important in high phototypes and in Asian skin. Because the post-inflammatory hyperpigmentation is a nightmare for me because it can last 6 months and patients complain all the time. Now I'm going to talk about rejuvenation. When we talk about rejuvenation, it's also improving pigmentation, dyschromia, but also skin texture, which is wrinkles and laxity. To treat all these parameters, you can do many things. You can use IPL for rejuvenation. You can use IPL. You can use radio frequency. You can use ultrasound fillers. You can use many things. So I'm just here giving you a new tool. And this new tool is the Picosecond Laser. It's very, very useful to do rejuvenation. As I said, I'm going to go through this, that we have different wavelength and we have different modes of action. This is very important to know what we can accomplish with every wavelength and what we can accomplish with different modes of actions. So with the different wavelengths, the 532, the 730, and the 785, these are to treat pigmented lesions in a burst mode. It's like explosion, single shot. With the 1064 that it goes deep, you improve skin quality, which means pore, wrinkles, skin laxity, and acne scars. So this is very important to choose the wavelength. When you want to choose the mode of action, as I said, the zoom, which is the toning, is like in the whole face, is when you want to treat something that is diffuse. The dyschromia, the skin texture, the explosion is single lesions or bursts. And the fractional is when you want to treat the whole face as well. And here what I'm saying with the fractional, you get these layers, which is this laser-induced optical breakdown. And this is going to remove the pigment, but as well is going to stimulate neocollagenogenesis. And the location, which is we're talking with Konica of the layers in the epidermis or in the dermis, is more related to the fluence than to the wave. So if you want to treat superficial, just go with very high fluence. If you want to treat something deep, acne scars, laxity, go to lower fluences. I'm going to share cases with you that, of course, you can treat with other devices, but if you have a Pico, you can treat them as well, being with a lot of efficacy, but at the same time with a lot of safety, which is very important. This is a patient that we did single lesions with the 730, and then the result 1064 in the whole face. Just see that this patient is a little bit tan. You are very safe with this. With an IPL, you are not that safe. With the Pico, you are very safe. And also I want to show you that you can see an improvement in the pigmentation, but as well in the skin texture, the wrinkles and the skin quality. I also always combine with bleaching creams, and if I can, and it's not something with retinol and sunscreen. This is another patient. I could do an IPL, yes, but the patient was a little bit tan. I want to be safe, always on the safe side. I treated with the 730 single lesions, and then with the 1064 resolved the whole face. This patient did 2 sessions. See that has more glow, the wrinkles improve. So it's a good tool to do rejuvenation. This is another patient that you can see dyschromia. You can see in Spain, I guess in Portugal as well, most people are tan. So with the Pico, you have a very good tool. You improve all the pigmented lesions, as well the diffuse pigmentation, but just look the skin quality. The skin quality has a lot of growth, the pore size, and you improve a little bit the laxity. This is another patient. In this patient, I tried the 532 Resolve Fusion, which is the new one. Here, the fluences are completely different. As you can see, the skin quality is extremely, extremely good. So, but this patient was a phototype 3. She was not very tan. I got very excited. So that's what happened to me with another patient. Is a patient is Asian skin. I wanted to treat with the 532 Fusion. As you can see, the skin quality is amazing. She was only able to do 1 session. Look at the pore size, how the pores are closed, the skin quality, but I could see all the lines of the passes I did. So be careful with the 532 in high phototypes. The patient was like this for 3 months. Eventually, they always go away. She was very happy with the skin quality. This picture, the patient sent it to me by WhatsApp. That's why the quality is not that good. But the skin quality is amazing with 1 session. But just be careful in skin phototypes, more than 2 to use the 532.
And do you think, if we just go back to this picture, do you think that you would be able to get this poor result with the 1064 resolve?
I think yes, but not in one session.
Not in one session.
This one is stronger, and the results are very good with the 1064. Actually, is the one I use all the time, and the pore size is very good. But in one session, the results here are amazing because you are treating 50% more. It's like you're doing like 2 sessions in one. But just be careful.
With fusion.
Yes, or just use bleaching creams before, prepare the skin, but you are treating more in one session with the 1064.
Yeah. And we have a couple of questions from the audience. What do you think your experience is now that you are treating this with laser along with creams? How much of the effect do you think is improvement from laser versus how much is improvement from creams, both for pigment as well as for texture?
Well, when I use bleaching creams with tranexamic acid, they don't do that much in skin improvement, skin quality. What they do is they avoid the pigmentation. Mm-hmm. So when I use the laser with bleaching creams, 99% is laser. I'm just using the bleaching creams to avoid hyperpigmentation. Another thing is when you add retinol. Retinol, for sure, it helps improving skin quality, but I would say 80% is laser, 20% are the creams. But I think laser, sometimes I like to prescribe creams, but not all the time patients want to buy creams because the laser is a little bit expensive. So sometimes it's like, okay, I have my creams and I still get good results. So I think the laser has 80% for sure. The creams combination always helps for sure.
And what about you, Dr. Santos? What is your feeling?
So we should think about the ability to penetrate our actives on the creams. And we know that beyond the dermal-epidermal junction is difficult to reach. And on some of these conditions, such as the PIH, such as melasma, that we have an impairment of dermal-epidermal junction barrier function, the creams are just not enough. So we need to add the laser and mainly the 1064 to reach the pigment over there. So if the pigment is only epidermal, we can use a cream, but we know that we need at least 12 weeks to reach a result. If we add a laser, we can safely get a better result and earlier than that only with the cream. So, but for me, the combination of both is a way to improve the safety and efficacy and the maintenance of the results.
Mm-hmm. That's a very interesting point you bring up. At this year's ASLMS conference, I know Dr. Eric Bernstein presented his experience treating with picosecond lasers with melasma. And in his study, he did not use any creams. He kept the study laser alone. And his experience was really quite impressive with out to 6-month follow-up with no creams in addition. And so that will be available for publication soon, but it was presented at ASLMS. And you're right, the laser plays a big part in the barrier function as well. What about one of the things that is also mentioned, and I want to call out one of our audience members, Christina Ona, who brings up a very interesting point and an interesting trick, and I don't know if you use it at all, but sometimes to make sure that the vasculature underneath is relieved from the treatment, do you ever put a glass slide over the pigmented lesion so that you don't get quite so much inflammation?
Who starts?
You go right ahead, Pedro. You sound like
okay.
You have
So the answer over there is get a 730, because if you have a 730, you somehow get out of the absorption curve of the hemoglobin, so you lower your risk of PIH by the vascular component. So It's where I set up the 730. You can use the 730 on two ways. If you have a dark lesion, you can do like chromophore density lowering with the 730 and need again a few weeks later with 532. Or if you have simple lentigos that are not that dark, you can treat them with a couple of sessions with the 730 or eventually with a single session without that risk. So if you don't have the 730 and you have to treat with the 532, it's a nice way to avoid the vascular part. But if you have a 730, you don't need to.
Very nice. And
Pedro, can I ask something to Pedro?
yeah.
Pedro, when you treat lentigos, which spot do you use with the 730?
It depends. If it's a medium hue, I usually go to the 3 millimeter with 1.6 to 1.8 joules per centimeter square. If it's darker, 4 millimeters with 1 joule, usually.
And Adriana, how about you? How do you select your spot sizes when you treat a pigmented lesion?
As well, depending on the color, because if it's very dark with low fluence is enough, then you can go with the 4 millimeters. But most of the times, the lesions are very, very light. So then sometimes I have to go to 2. Have to go to spot of 2 because it's the only way to get the 4 millijoules.
And I think in general, choosing the largest spot size is the lowest energy. You want to create the treatment endpoint with the lowest energy possible.
Yeah.
Mm-hmm.
But if you don't have the treatment endpoint, you have to drop the spot size.
Yes.
Or eventually change up the most the wavelength. If you cannot reach your endpoint with the 730, you should move to the 532 if the phototype allows you to.
Mm-hmm.
At last resource.
Yes. Wonderful. Well, let me turn this over now to you, Pedro, and your section on tattoo removal, as well as some additional pointers on rejuvenation. Okay,
let's move on with our next topic, tattoo removal. And basically, I would like to cover with you all of the whole process of tattoo removal and the variables that we need to account for to have a nice treatment flow and to give the best results possible. So when we think about tattoos, we think in a world or eventually in a universe, such as the people that we can see on Shibuya Terminal Crossing. Because when we talk about tattoos, we are talking about the cosmetic ones, even the permanent makeup, the artistic, either professional or amateur, the traumatic ones, and the medical ones, such as for radiotherapy. So it's almost impossible to standardize treatments with this whole bunch of different things that we are looking at. And said that, we need to set up several variables to account for to set up our treatment. First of all, the type of tattoo, the pigment density, the color or colors present at the tattoo, the tattoo age, the body location, and the individual response to the pigment and to the treatment. Let me point out mainly the body location, because the body location will influence the rate of clearance of the tattoo, because we rely on our lymphatic system to have the clearance or part of the clearance of the pigment, and the lymphatic flow and speed is different at different body sites. So our interval between treatments will be different with different body locations, mainly for this reason. So what are we doing to the tattoo when we laser it? First of all, we already discussed that we are looking at photoacoustic lasers. So we are transforming the light energy on a mechanic or acoustic energy. And basically, if the mechanic energy that we are delivering is sufficient enough to put the pigment vibrating at the point that it breaks, it's called the resonance point, basically we will start to disperse and fragment the pigment. if the particles that we are generating are small enough, they will be phagocytized and then removed by the lymphatic circulation. So, said that, we need to account that we'll need several sessions to get our result. Why? First of all, we all know these typical images for tattoo removal, that is the pseudo-frosting effect, this whitish aspect that we see. And this is due to, as the pigment is being broken, it's generating nitrogen, gaseous nitrogen that forms like a cloud inside the skin. And as this cloud of gas is white, it works as an optical shield, as we know. When we want to cover something to not be lazed on, we paint it with a white pencil. So basically the rationale is the same. And as this works as an optical shield, we cannot reach all of the layers of the tattoo with a single pass or a single treatment. Beyond that, we cannot break the pigment at once. So we usually, with the first sessions, what we are doing is eroding the pigment and generating small particles from the surface at the point that the energy that we deliver is sufficient enough to break up the pigment. That's why on tattoos that are with a heavy density of color, usually we see just the fading on the first 3 treatments eventually, and after that, boom, a speed up on the clearance of the pigment. Another issue that we know that happens is that when we laze the pigment and the oxides of some metals that we have on the inks, we induce some chemical changes on the structure of the pigment that can allow somehow to progress to colorless state. So what we see is when we combine the cleavage of the pigment with the dispersion of the pigment and this photochemical discoloration, we get to our results, to our final result, that is the tattoo removal. So the elephant in the room, nano versus pico. Where is the actual difference? First of all, the physical one. We know that when we lower the pulse duration, we are moving to a more pure photomechanical interaction. And beyond that, we know that only on the picosecond domain, we can generate plasma in sufficient amount to induce tissue set changes. So that's why we can generate more eventually ablative effect, but beyond that, and rather than that, a more intense particle vibration and cleavage rather than compared with the nanosecond lasers. And this is backed up with several publications, and we see that we have more and more uniform dispersion from the pigment when lasered with picosecond versus the nano. About and concerning tattoo removal, we see that picosecond laser is reducing the number of sessions that we need, and that is a statistically significant superiority of picosecond lasers on tattoo removal. And basically we are moving towards setting up the picosecond lasers to the gold standard on tattoo removal. And this is an example comparing an ex vivo experience, lasing a tube of pigment and analyzing it at electron microscopy, and we see that the particles that are generated after the picosecond laser are infinitely more smaller and more even and more dispersed rather than compared with the nanosecond domain laser. Moving on to the wavelength selection, here we have to think about colors. And usually, as we learn on our first years of school, we have the main and the complementary colors. And basically, this is the association that we need to use. We need to treat with the complementary color that we are facing on. So when treating dark colors, we don't think about this, but we move straight forward to Nd:YAG, 1064 wavelength. And why to think directly on 1064 rather, for instance, on 755? I always like to point out this comparison, because the 755 has an profile of absorption that is pretty intense. So if you treat a very dense tattoo, a dark colored tattoo with a 755, what you should expect is blistering, almost mandatory, because you have an intense interaction between the laser and the pigment. So if you treat with Nd:YAG, you have two things to add on. First of all, you have a less significant interaction, but that can cover several layers of the tattoo at a single treatment without this risk of blistering that up to most can lead to scarring and to remove a problem to install another. Talking and discussing about the other colors, when we talk about red, yellow, and orange, the main complementary wavelength is at the green part of the spectrum. So we talk about 532. And when we talk about blue, green, and light purple, we move to the reddish part of the spectrum. And here we have our 730 as the main star. Discussing difficult or impossible colors, we know that white color is reflective, so it's almost impossible to remove. Why do I say almost? Because if we treat with a low wavelength, such as the 532, sometimes from small particles of iron that color has, it can have like an inversion effect and darkening the white one. The problem is that the reaction is not predictable. So we can eventually try on a little bit, but we cannot assure that we'll have this inversion effect. And if we have the inversion effect, we will treat the tattoo as the result color that we get from the inversion. On the pale yellow and pale blue, on the pale blue, the problem is similar as the white color. On the pale yellow, the complementary color is on the UV domain, and we don't have any laser that works on a picosecond laser that works on this domain. So it's quite difficult to reach that color too. So revising pretty quickly, we'll work with 3 wavelengths, the 532 at 375 picoseconds, the 1064 at 450, and the 730 with 250 picoseconds. It's actually the shortest pulse duration that we have available on the market. Algorithm of treatment. First of all, the basics: anamnesis, photos, and informed consent. Pretty well cleanse the area of treatment, and please use always anesthetic, because it's one of the more painful treatments that we can offer to our patients. And here you can use either topical or injected anesthetic. I always like to add on the Zimmer, the cold air, to improve the comfort, mainly if I use topical anesthetic. Please have in mind that we are using several wavelengths, and we have to provide to the patient, and for you too, obviously, protection, ocular protection that covers all of the wavelengths that we are working on. If you treat permanent eyeliner, please use intraocular shields. The beam should always be applied at 90 degrees to the skin. We should reduce the overlapping and thus use slow repetition rates, because if we overlap or stack too much, we increase the risk of blistering and of fibrosis. And that's why I recommend you not to use a repetition rate not higher than 6 Hertz for this reason, and also for pain management. We should start with bigger spot size to try to get the major depth that we can reach at a single pass, and reducing the spot size as we are retreating the patient to generate more fluence per area. Our endpoint is a mild frosting, not a yellowish one, not either with pinpoint bleeding. If you are at that point, you are over the fluence that you need to treat, and you are on the risk of having complications. Okay, and an advice not to treat 360 tattoos at once because of the risk of compartment syndrome. So you should split on 2 different sessions that tattoo. Here we have a video showing the endpoint that we are looking for. No, sorry. Let's wait for the video to start. Okay.
Let me try that. I'll hit it once.
Okay, as you see, this is the first treatment of this tattoo, and we see a pale frosting, not a pretty whitish intense one without any yellow colored zones or even without any pinpoint bleeding. Okay. What should we expect as the post procedure? I think that the slide hasn't already moved on. Okay, now it is. So edema and erythema up to 48 hours. Eventually the pigment, more superficial pigment, can form a very thin crust. And if we face blistering, we might face 2 different problems. And the time frame at the blistering occurs will tell us the problem that we had. First of all, if we have blistering on the first hours after treatment, usually is due to an hypersensitivity reaction to the pigment. And it's like the cooking vegetable effect. You know that if you split the vegetable and increase the surface area of the vegetable to cook it, you will cook it faster. Here, as we are cutting the pigment and breaking the pigment apart, the surface of contact of the pigment with the body is increased. So if we have a prior sensitization with the tattooing, here we will expose more surface of the pigment to the body, and we'll have an hypersensitive reaction. If this blistering occurs only 48 to 72 hours post-treatment, here is due to excessive fluence on the treatment. As aftercare, you should prescribe a repairing cream on a fixed regimen, at least twice daily, and you can recommend to the patient to eventually apply more times per day for increased comfort, but on his demand. And obviously sun protection. If we are talking about removing PMU on the face, usually I like to prescribe a low potency corticosteroid for 5 days. And obviously sun protection too. And we should recommend to the patient to avoid sun exposure until complete skin healing. Time between sessions. As I told you, we are here dependent to the clearance of the pigment by the phagocytosis and the lymphatic drainage. So if we are discussing face tattoos, we have to leave a minimum of 4 weeks between treatments. Trunk and proximal limbs, 8 weeks minimum. Distal limbs from the elbow to below or to distal, and from the knee to distal, 12 weeks minimum. And we are discussing minimum times. We can leave more time between sessions. We know that if we leave more time between sessions, eventually we can have a greater result. But we have to wait somehow, elongating the time, the total time of treatment to years rather than months while facing these 2 components. So at least these times, if you can, and the patient wants to wait a little bit longer, you can, because you know that is beneficial, but not at that point that will make the treatment last an eternity. Number of sessions and prognosis. We know that we have some scales that helps us to define the number of sessions, and the most widely used is the Kirby Design one, and it's pretty accurate. It was made mainly for nanosecond lasers. You should expect 20% less more sessions with the picoseconds with picosecond laser when compared with the nanosecond one. Beyond that, when you finish the tattoo removal, it's usual to have like a pale, a whitish shadow of the tattoo. That is some removal of some melanin on the tattoo. Usually it's temporary. If it's permanent, usually it's due to some fibrosis that was induced by the traumatism, by the trauma on the tattooing itself, rather than on the removal. And another issue that we have to cover with the patient and discuss with the patient is that if we have scars within the tattoo, if we have hypertrophic zones and so on, eventually we will need to treat them afterwards, removing the pigment, and eventually they can become more visible when we remove the pigment, because we lose somehow the fading and the covering effect that the pigment exerts over there. Discussing some advanced procedures that we can do to speed up the tattoo removal. We have somehow all this R20 protocol, where we treat 4 times the tattoo, waiting 20 minutes between these times, each time, to allow the body to absorb the nitrogen and to fade out the frosting, to allow to irradiate another level and layer of the tattoo. But I think that it's not affordable, neither for us, neither for the patient, to be at least 1 hour at the clinic to remove the tattoo. So beyond that, we have the PFT patches that help us to remove transepidermally some pigment. And for me, the future and almost the present is using a combination between full beam and fractional strategies at the same session. And here we can address it both ways, or using a fractional ablative laser, or using our fractional pico that can work as a fractional ablative laser too. And it's already published, and we have data of this combination, that when we combine these 2 strategies, we have less adverse effects, less sessions needed, less side effects from the treatment, and we have the best of both worlds, because we are treating either the pigment and either the skin texture at the same time. For me, what I actually do is to combine picosecond laser on a fractional and a non-fractional way. Usually I start with the fractional and I end up with the full beam. Why to do on this order? First of all, I use on a pretty high energy, because I want to be subablative, and usually the lowest energy that I use with Resolve 1064 to do this is 1.9 millijoules per pixel. And I just wait a couple minutes to defrosting to reduce a little bit, usually 3 to 5 minutes with a little bit of cold on top, and I perform the regular zoom and piece on the top. And actually we see this improvement either on the textural changes that we see on the tattoo, and either we see some speeding up of the process when we combine these strategies. Some results of using PicoWay system removing tattoos. Here, pale blue, pretty difficult color to use and to treat. With the 730, please have in mind that the 730 works at a 250 picoseconds pulse duration, so we can induce a nice amount of cavitation over here and resonance over here. And with only 4 treatments, basically we are left just only the whitish part that has more titanium dioxide, and eventually is more difficult to reach or almost impossible. But it's a nice result to pretty nice result to pale blue colored tattoo. After 7 treatments of multicolored tattoo, we have a slight residue on the top, and on this case, please have in mind that we have some pigment migration, some dermal insufficiency that usually predicts a more difficult treatment and a more sparse result, but it's a very nice result over here. And please have in mind that we are seeing a final result only 8 weeks after the 7th treatment. So we expect this to improve on the next 6 months. Here, with only a single treatment of this tattoo that is monocolored on black, a pretty nice pigment reduction. Obviously, this is a painting. You have a less density of the pigment, so it's easier to address. Here, taking out the blue mainly, and with a single treatment, we have almost all of the blue removed. Again, with the here not with the 730, but the elder brother, the 785 that almost 730 has replaced somehow because it has a shorter post duration, and this tune up on the wavelength makes difference. Here, a tattoo that is pretty dense on the pigment with only 2 treatments. Even on the red, we have a nice reduction on the pigment density. And here, a dolphin with black and blue with only a single treatment. We have more than 90% of the pigment removed. And this is at the clinic, our ex libris case, because this actually is a cover-up. Beyond this tattoo, there was like red hearts with some wings, multicolored and so on. And only after 5 treatments, the bottom tattoo is almost gone, and we only have a residue of the black ink. And please have in mind the density the density starting point where we started. So for me, with 5 sessions is a pretty nice result. And please notice the skin texture that is almost untouched. For closing this part, first of all, we have to know and to let our patients know that the removal of the tattoo is a process and it takes time. And the time is a variable that we have to account for, not only for the total of treatment, but also between treatments, as we have discussed the location of the tattoo and the lymphatic drainage. We also have checked that Picosecond Laser are gaining evidence towards being the gold standard on tattoo removal regarding the increased efficacy and safety that they provide to us. And the approach of using the combination of fractional picosecond and full beam picosecond is the way to go to improve the safety and the efficacy on tattoo removal. And saying this, the PicoWay gives us weapons to deal with all of these cases. So with this unique wavelength 730 and also the shortest post duration that we have on the market. Thank you.